Good morning all of you. Today I'll take class on the acute gingival infections. The most common gingival infections are the necrotizing ulcerative gingivitis, herpetic gingival stomatitis and the perichoronitis. First we'll discuss necrotizing ulcerative gingivitis. So basically it is also called as NUAG-NUG, necrotic ulcerative gingivitis. It is a microbial disease of gingiva with impaired host response. And there is the death and the sloughing of gingival tissue. As you seen in this picture, there is the sloughing of gingival tissue. Some clinical features are like it is an acute condition, sometimes subacute also, which undergoes reduction in severity without treatment, and recurrence is also very common, and the most common site is the anterior region. The sudden onset shows the histories. Some debilitating disease also comes in the history of ANUG. Some changes in living habits, poor nutrition, tobacco use, and the psychological stress also leads to acute necrotizing ulcerative gingivitis. Now comes to the oral signs. Basically, ANUG is a punched out crater-like depression. And at the crest of interdental papilla, as you can see in this picture, there is a gray pseudomembranous slough present at the gingival region. Red, shiny and hemorrhagic gingival surface is there. Spontaneous gingival hemorrhage or pronounced bleeding occur just after slight stimulation. Fetid odor and increased salivation is also present in acute necrotizing ulcerative gingivitis. But remember one thing, there is no any pocket formation. Some oral symptoms like lesions is extremely sensitive to touch, constant radiating, gnawing pain increases by spicy and hot foods, metallic foul taste is also present, and excessive amount of pasty saliva is there. Now comes to the extraoral and systematic signs and symptoms. For mild cases, there is local lymphadenopathy, elevated body temperature. For severe cases, there is high fever, increased pulse rate, leukocytosis, loss of appetite, and the general lassitude. Some systemic reaction like insomnia, constipation, GI disorders, headache, and mental depression also occurs. Coming to the clinical course of acute necrotizing ulcerative gingivitis. In first stage, there are 7 stages in this. In stage 1, there is necrosis of the tip of interdental papilla, which we call the ANUG or necrotizing ulcerative gingivitis. In stage 2, there is necrosis of entire papilla, which occurs in the NUG and the necrotizing ulcerative periodontitis, which we call NUP. In stage 3, the necrosis extending into the gingival margin, which is a clinical feature of necrotizing ulcerative periodontitis. In stage 4, there is necrosis extending also into attached gingiva, which we also seen in the necrotizing ulcerative periodontitis. Stage 5 is necrosis extending into buccal and labial mucosa. And the stage 6, necrosing exposing alveolar bone, which we call necrotizing stomatitis. And the last stage 7, which we call the noma. In this, the necrosing perforating the skin of cheek. Coming to the etiology of ANUG. Basically, the role of bacteria is most important in the etiology of ANUG. In this, the spirochetal microorganisms like fusiform bacilli or Prevotella intermedia and Fusobacterium celluminas is the main bacteria which cause the ANUG. Some role of host response is also seen in the etiology of ANUG, like immunodeficiency, some underlying systemic disease, any nutritional deficiency or stress, alcohol or sometimes drug abuse, and HIV condition may also leads to ANUG. Other local predisposing factor which also leads to ANUG are pre-existing gingivitis, some injury to gingiva by trauma or any laceration. Smoking also leads to aggravate this factor. Any pericorona flap and the malocclusion. These all predisposing factors leads to the ANAG. Some systematic predisposing factor like any nutritional deficiency or any debilitating diseases. And psychosomatic factors like stressful condition, as I have told you, psychological disturbances and increased adrenocortical secretions also leads to ANAG. But remember one thing, it is a non-communicable disease. It is a non-communicable, this is not an contagious. Next comes to the treatment of ANAG. In the first visit, we do complete evaluation of patients with antibiotic and analgesics. We rinse with 3% hydrogen peroxide and warm water every 2 hours. We advise for adequate rest and we avoid scaling and any extraction until 4 weeks to the patient. Then we recall patient for the second visit after 1 to 2 days later. We do the same similar instructions to the patient, but we can do scaling here. Next comes the third visit, which is after 5 days. Remember this thing? This is frequently asked question. After 5 days, we recall for the third visit. In this further treatment after the evaluation we will done, we can do gingivoplasty. We started supportive periodontal treatment process and nutrition supplements started. The next acute gingival condition is primary herpetic gingivostomatitis. It is basically caused by herpes simplex virus 1 infection. It is an asymptomatic, generally occurs in infants and children in less than 6 years of age. Frequency is basically male and female equally affected. Coming to clinical feature, oral signs, there is diffuse erythematous shiny gingiva, spherical gray vesicle present on gingiva. The most common sites are gingiva, labial and buccal mucosa, soft palate, pharynx, sublingual mucosa and tongue. And after 24 hours, there is ruptures of vesicles which leads to small ulcer with red elevated margins and depressed yellowish or grayish white portion. Next, the oral symptoms. The generalized soreness of oral cavity present. Difficulty in eating and drinking is also there. Ulcer on focal site with pain and sensitive to touch, and thermal changes also occur at the site. Some extraoral and systemic signs like cervical adenitis and high grade fever also present in primary herpetic gingivostomatitis. Next, the question is how we diagnose this herpetic gingivostomatitis. This is by taking the clinical history from the patient. We ask about any changes recently occurs. Then we do clinical examination followed by viral culture and immunological test, and we can also do DNA hybridization technique for diagnosis. Some differential diagnosis of acute herpetic gingivostomatitis like erythema multiforme, bullous lichen planus and recurrent aphthous stomatitis. Next comes the treatment of primary herpetic gingivostomatitis. Basically, it is a self-limiting disease. It's self-limiting and it self-limiting after 7 to 10 days. And in this, we give antiviral therapy before 3 days of onset, 15 mg per kg of acyclovir 5 times a day for 7 days. Remember this is very important. 15 mg per kg of acyclovir 5 times a day for 7 days. And it reduces the severity of symptoms. But after 3 days, we started palliative care. This picture shows some difference between necrotizing ulcerative gingivitis and primary herpetic gingivostomatitis. As I already told you, etiology for necrotizing ulcerative gingivitis is basically bacteria, and for primary herpetic it is in viral etiology. For ANAG, it is a necrotizing condition, but in herpetic gingivostomatitis there is diffuse erythema and the vesicular eruption present. In ANAG, punched out crater-like margin pseudomembranous slough is present, but in primary herpetic gingivostomatitis there is diffuse involvement of gingiva and may include buccal mucosa and lip also. uncommon in children, but herpetic gingival stomatitis most commonly occur in children only. And in ANAC there is no any definite duration, but for primary herpetic gingival stomatitis there is duration of 7 to 10 days. The next comes the last acute gingival lesion or conditions is perichoronitis. So what is perichoronitis? It is an inflammation of gingiva in relation to crown of an incompletely erupted tooth, and basically it occurs in the mandibular third molar area. It is an acute condition, maybe subacute and chronic also. This we can see in this picture the perichoronitis completely. This is the pericoronal flap, and this is the mandibular third molar area, and it is an unerupted teeth, and basically perichoronitis occur in this unerupted teeth only. Some clinical features of perichoronitis like space actor area of food lodgement and bacterial growth, exacerbated by trauma, some occlusion, foreign body trapped underneath the tissue and or pericoronal flap. There is a red swollen separative lesion which is tender with radiating pain to ear, throat and floor of the mouth. There is swelling of jaws, lymphadenopathy, and systemic symptoms is also present like high grade fever and all. The complications of perichoronitis include involvement of submaxillary, posterior cervical, deep cervical and retropharyngeal lymph nodes. Sometimes the peritonsillar abscess formation, cellulitis and Ludwig's angina also occurs. Next comes the treatment of perichoronitis. For treatment purpose, we do gently flushing the area with warm or saline water, swabbing with antiseptic after elevating the flap gently from the tooth. We recommend antibiotics for 5 days, and after subside of inflammation, we can do operculectomy. And if operculectomy is not indicated, we can go for extraction also. As we can see in this picture, this is a clear-cut case of perichoronitis when pericoronal flap is present on the distal end of mandibular third molar. In this, first of all, we do the thoroughly subgingival scaling and curettage. After that, we remove this pericoronal flap from the distal part of third molar, as you can see in this picture. So the most important treatment in this perichoronitis, you have to prevent food lodgement on the pericoronal flap area. Thank you.